Welcome back. It's Jessica Hoy. Sorry, my dog just knocked into the computer and it made it jiggle a little bit. This is going to be chapter 3 of pneumonia. We've been talking about some pathophysiology. We've been talking about some more generalities surrounding pneumonia. And now we're going to get into, it's me, meat and potatoes of nursing management of pneumonia. So we're going to start with our assessment. I'm going to share my screen so you can see where I'm at. Okay, so we're going to be starting with subjective data, right? We're going to be interviewing the client or their support person that comes with them and getting some information. Past medical history, including any sort of lung cancer, COPD, that chronic obstructive pulmonary disorder. Diabetes really impacts a variety of things, including the body's ability to fight off a pneumonia, any malnutrition, any sort of chronic debilitating disease, any history of autoimmune disease, use of antibiotics, corticosteroids, chemotherapy, immunosuppressants. Our cancer patients are highly suspect and highly, we're always on the alert for pneumonia with them. Any recent abdominal or thoracic surgery, any recent intubation, and any history of tube feedings. And I talked a little bit about this when I was going through chapter 1. So any abdominal or thoracic surgery, you end up getting intubated for those. Any sort of abdominal, you're going to be, there's a possibility for you to have those gastric contents go up from the esophagus, but not quite out the mouth, and instead go down the trachea. And tube feedings that happens, it's a highly suspect. We're always watching for people who have tube feedings and high alert for them they're on pneumonia watch, basically, because any sort of lowering the head less than 30 degrees puts them at a high risk for having an aspiration of their tube feeding contents into their lungs. We're also going to be taking a look at functional health patterns. So functional health patterns is, how do you feel? What's your health perception? What's your health maintenance? We'll take a look at smoking, alcoholism, their alcohol intake, any sort of respiratory infections. How have they been like in general in terms of their energy level? How much malaise have they or have they not been experiencing? How is their nutrition? Are they able to eat? When it says anorexia here, please don't confuse anorexia with anorexia nervosa. Anorexia nervosa is a condition where body image is tied in with eating. Anorexia in general means they're not eating, regardless of their own perceived body image. Nausea, vomiting, and chills. Nausea, vomiting, and chills can create an increased need for nutrition, but definitely not an increased want. So how have they been doing in terms of taking in food? How's their activity been lately? Are they been, like in general, are they on bed rest? Have they just been laying in bed for a few days? Are they really tired? Are they more weak than normal? Are they having difficulty breathing? Their cough? How's any nasal congestion going? Nasal congestion can lead us to, maybe that upper respiratory infection is causing that pneumonia. Sorry, I just about said pneumonia again. And then cognitive perception. So are you having pain when you're breathing? Are you having chest pain? Are you coughing so much that all of the little muscles between your ribs are just tired and achy and sore, or maybe more than that? People can cough so hard they can break a rib. How is your throat? How's your abdominal pain? Are you coughing so hard that all those core muscles are getting too much of a workout and you're having pain? Are you having a headache? Are there muscle aches? As well as we're going to be looking at objective data. And all of this stuff is in table 27.7 in Lewis. So we're going to be doing vital signs. We're going to be taking a look at their temperature. We're going to be using our eyes to really observe for restlessness or for lethargy, splinting of any sort of affective areas. So like if they're holding their hands to their chest, And then we're going to be taking a look at some more objective data in terms of the respiratory system. So we're going to take a look at the respiration rate, see if they have any tachypnea. We're going to be looking at chest movements. Are they symmetrical or are they asymmetrical? Are they using their respiratory muscles? Are they flaring their nose? How is their breathing out? Do we hear any crackles? Do we hear friction rub? Do we feel dullness on percussion? Do we hear fremitus, which is when you're palpating on the skin and it sounds like Rice Krispies. Like it literally sounds like a bowl of Rice Krispies with the air popping in there. And we're going to take a look at the sputum that they are able to expectorate and the color of it. In addition, we're going to be looking, here's our nursing assessment in general. We're going to be taking a look at that heart rate. What is our heart rate? Is it tachy or normal? Neurologic changes in mental status. Here's where I want to make a very important point. More often than not, in your older adult, you will have a change in mental status with an infection before you will have tachycardia and any sort of changes in vital signs. Let me say this again. You will have LOC changes in your older adults when they have infections before you will have vital signs changes. And it has to do with the oxygen exchange, and it has to do with, so whenever you have somebody who has a change in mental status, but everything else kind of looks normal, start looking at their, encourage people to start looking at their blood studies to see if you can't see an increase in WBCs, just to let you know. So possible diagnostic findings in those labs, increased WBCs. You can have abnormal arterial blood gases. If that gas exchange isn't going the right way, you will have changes in the ABGs. Their pHs will change as well as their PaCO2 and their PaO2. You'll have positive sputum and you'll have abnormal chest x-rays. So the most common manifestations are a cough. Either they're getting stuff out, productive, or they're not getting anything out, non-productive. It could be green, that beautiful sputum could be yellow, or it could even be rust colored. There could be fever and chills associated with this, painful breathing, lots of breathing, dyspnea, tachypnea, and then we could have some pleuritic chest pain where like it's not necessarily like myocardial chest pain. We'll get to that later in the semester, but pleuritic chest pain where just the act of breathing because of the inflammation hurts. In older or debilitated patients, remember in the last slide when I was talking about mental changes? Here I'm going to talk about it again. That's how important it is. In your older or debilitated patients, LOC changes, confusion or super or hypothermia will be a common manifestation. When we do our physical exam, we will hear with our handy dandy stethoscopes some fine or coarse crackles. Fine crackles sound like if you were rubbing your hair next to your ear. That is that air kind of moving through little bits of accumulation in the lungs. You can have coarse crackles. When we have consolidation in the lungs, we'll have bronchial breath sounds, so we can actually hear the air going through bronchus. We'll have egophony, we'll have increased fremitus, and then when there is a pleural effusion, when we do our percussion on that thoracic cavity, we won't really hear anything. It'll just sound dull rather than hollow like what we're expecting. So possible nursing diagnoses that we're going to be working with clients, possible problem list that we're going to be working with clients with pneumonia are these. Impaired gas exchange. Not enough CO2 and O2 exchanging places there. Impaired breathing, which can lead to impaired gas exchange. Fluid imbalance. If those secretions are too thick to be able to get out, that's a fluid imbalance situation. The other thing is because these patients have some sort of fever, perhaps, and because the body is moving everything it possibly can to the lungs, including extra fluids, They may be dehydrated because of all of the work that's associated and all of the different shifts that are associated with pneumonia. Hyperthermia, aka fever, and activity intolerance. So I'm going to stop sharing my screen here. So we've gone through assessment and we've gone through diagnosis. Now we're going to be getting to planning and interventions in the next chapter. So stay tuned for chapter 4.